Bismillahirrahmanirrahim. I have the pleasure to be here for the second time, participating in the ENT radiology course sponsored by AstraZeneca. In this meeting, we are going to talk about the sinonasal imaging. And actually, you all know that to examine the nose and the paranasal sinuses, in the radiology, we have two main examinations. The first one, which is known as the routine study, and this is performed while the patient lies in the prone position, and we obtain a coronal scanogram. Then we identify the area to be examined from the posterior wall of the sphenoid sinus, and we proceed anteriorly until we finish the frontal sinus, and we usually align the scans perpendicular to the heart belt. Then we proceed from posterior to anterior, having sections every 3 to 5 millimeters, and we project the images in what we call the bone window setting. Then the second study is the full study, which includes, beside the coronal scans, includes axial scans. And the axial scans are obtained while the patient in the supine position. Then we take a supine scanogram. We start from the level of the heart palate, and we proceed upward until we finish the frontal sinus. The same sectioning every 3 to 5 millimeter slices. Then in the full study, we obtain also the coronal scans. We have axial scans and the coronal scans, and we also scan the brain as well. And then the scanning of the brain starts from the skull base and proceeds superiorly until we reach the skull vault. This is the full study, and the previous one is the routine study. And after we have the images, we usually display the images in what we call the bone window images, where we can see the bony structures, but the soft tissues are not well projected. But in the full study, we should have bone window and the soft tissue window for the brain and for the paranasal sinuses as well. Then if we have the newer machines, the multi-slice machines, we can obtain 3D images like this, including the skull, the face, and the region of the paranasal sinuses, as well as the mandible. These are the previously performed 3D reconstruction images on the older machines, but in the recent machines we can have a very smooth, very well-informed images like this. Then we are going to have a quick review of the anatomy of the paranasal sinuses. Then we'll concentrate on some of the specific items that are of interest to the clinicians. In the axial images, while the patient is facing up, then facing anteriorly, you can see the root, or you can see the start of the maxillary sinus on both sides. And this is the mandibular ramus. Here is the styloid process, and this is the cervical spine. Then if we go up, then you can see the maxillary sinus, and attach it to its posterior aspect, the pterygoid plates. In between the pterygoid plates, you can see the pterygoid fossa. Then this is the mandibular ramus, and this is the styloid process. The same anatomy here. This is the maxillary sinus, and this is the zygomatic bone, the mandibular ramus, and the styloid process, the pterygoid plates, and the pterygoid fossa, the nasal cavity, the bony nasal septum, and the inferior nasal turbinate. Then going more up, you can see the maxillary sinus. You can see also the zygomatic bone and the zygomatic arch. And this small circle represents the nasolacrimal duct. This is the nasal bones, nasal septum, and the nasal cavity, the inferior turbinate. Here you can see the maxillary sinus, the nasolacrimal duct, the nasal bones, the zygomatic arch, the mandibular condyle. And more up, you can see the upper part of the maxillary sinus. This is the sphenoid sinus, the nasolacrimal duct, the nasal bones, and the orbit. More up, you can see the ethmoidal air cells and the sphenoid sinus, and you end the scan by reaching the frontal sinus in the axial images. Then in the coronal scans, you start from posterior to the sphenoid sinus, going anteriorly until you reach the level of the frontal sinus also. And here you can see this is the sphenoid sinus with multiple intrasinus bony septations. This is the sphenoid sinus left compartment and right compartment. Then going more anterior, you can see the sphenoid sinus on both sides. And this is the orbital apex on the left and on the right. This is the nasal fossa. This is the bony nasal septum, inferior turbinate, middle turbinate. Then you go to anterior to the ethmoidal air cells and you see the maxillary sinus, inferior concha, middle concha, and this is the bony nasal septum and the hard palate. Then if you go more anterior, you can see the orbital cavity on both sides, the ethmoidal air cells, the maxillary sinus, the bony nasal septum, the nasal concha. More anteriorly, you can see this is the cribriform plate of ethmoids, and this is the crista galli, and here is the orbit on the left and on the right. In the orbital floor, you can identify this orbital foramen, which is the canal for the inferior orbital nerve. Then this is the maxillary sinus, inferior concha, middle concha. Then if you go more anterior, you will reach finally the frontal sinus as the end of the scan. This is the most anterior part of the maxillary sinus. Then if you go deep and to see more of the anatomic details, then you can look at the maxillary sinus. This is the infraorbital canal, and this is the pathway of what we call the osteomeatal unit. It starts by the maxillary ostium, running through the ethmoid infundibulum, reaching the hiatus semilunaris, ending by the middle meatus. Then this is the what we call the osteomeatal unit. It is bordered laterally by the orbital floor and medially by the uncinate process. Then if you look to this arrow, this is the infraorbital canal, which contains the nerve, artery and vein. Then this is the maxillary sinus, and this is the osteomeatal unit, as I have mentioned. Look to this image. This arrow actually indicates the start of the osteomeatal unit. It is not referring to the site of the maxillary ostium, of course, but if you follow these arrows, you will follow the osteomeatal unit or the osteomeatal complex, starting by the ostium, passing through the ethmoid infundibulum, then the hiatus semilunaris, then the middle fossa. And you know actually that this is the uncinate process and this is the infraorbital margin. Here is the maxillary sinus, and you can magnify this image and you can see the same anatomy. This is the osteomeatal unit, starting by the ostium, ethmoid infundibulum. This is the pathway of the ethmoid infundibulum. Then you reach the hiatus semilunaris and you reach the middle fossa as well. Then a few words about the ethmoidal air cells, and you know there are three components. The horizontal plate, which is the cribriform plate, this fine plate at the floor of the anterior cranial fossa, and the vertical plate, which represents the crista galli, and the ethmoid sinuses, which are separated by the lamina papyracea of both orbits. Then you know that this place is the place for the gyrus rectus and the olfactory bulb, which rest on the cribriform plate of ethmoids. The ethmoidal air cells are divided into two main groups. The anterior group are formed of smaller cells that are more numerous and they drain in the middle meatus. These are the anterior ethmoidal air cells in the axial view. And the posterior group, which are larger and fewer in number and drain in the superior meatus. You know that the Unodi cell is the largest, most posteriorly located ethmoidal air cell. This is the site of the Unodi cell, and it is intimately related to the sphenoid sinus. Also, it has a good relation to the optic nerve canal. This is what we call the Unodi cell. Then the Heller cell is one of the normal variants that is located in the inferior orbital margin or the inferior medial aspect of the orbit, and it has an intimate relation to the ethmoid infundibulum, and it can compromise the osteomeatal complex. This is an example of a Haller cell, and this is another example of a Haller cell that are more larger and encroach significantly on the osteomeatal unit. The ethmoidal bulla is the largest ethmoid air cell that has intimate relation to the osteomeatal complex. And this is the site of the osteomeatal complex, and here you can identify the ethmoid bulla, which is the largest ethmoid air cell intimately related to the osteomeatal complex. This is the ethmoid bulla. Then if you look here, this is the anatomy of the middle turbinate, and you know that the middle turbinate has an attachment superiorly to the cribriform plate of ethmoids. This is the attachment of the middle turbinate to the cribriform plate of ethmoids, and it has also a lateral attachment to the medial orbital wall, which is known as the basal lamella, and I will show you in a moment. The lateral lamella is this plate, which is very fine in between the located lateral to the attachment of the middle turbinate to the cribriform plate. This is the site of the lateral lamella, and here is the site of the lateral lamella. It is also known as the fovea ethmoidalis. And here you can follow this line, which shows the attachment of the middle turbinate to the lamina papyracea, or to the medial orbital wall, and this is what we call the basal lamella. In between the basal lamella and the ethmoidal bulla, there is a small air space which is known as the sinus lateralis. And this sinus lateralis is an inconstant space lying between the ethmoid bulla, which is the largest ethmoidal air cell intimately related to the osteomeatal unit, and the basal lamella, which is the lateral attachment of the middle turbinate to the medial orbital wall. So, now. أيوة. Supra. Okay. It's another name for the lateral sinus. Okay. Then he came to the frontal sinus, and the frontal sinus is seen in the sagittal and the coronal images. This is the frontal sinus in the coronal, the frontal sinus in the sagittal images, and the frontal sinus drains in the anterior aspect of the middle meatus by the canal, which is considered an integral part of the ethmoidal complex, and this is the approximate site of this canal as seen in the sagittal and the coronal planes. Then you came to the sphenoid sinus, which is superiorly related to the pituitary fossa. This is the pituitary fossa, and this is the sphenoid sinus. And inferiorly it is related to the nasopharynx, and on both sides it is related to the site of the cavernous sinus. And this sinus may expand, or the aeration may extend into the skull base and also into the pterygoid blades. The sinus opens anteriorly in the sphenoethmoidal recess posterior to the superior concha, and you can see the site of the opening in the sagittal view, and you can also see it in the axial images as well. Then there are some of the anatomic variants, including the nasal septum variants, which may be deviated either to the left or to the right, or you may have a nasal septum spare like this one, or you may have a pneumatization of the bony nasal septum. The middle turbinate commonly shows what we call concavulosum, meaning pneumatization of the middle turbinate, which may be unilateral or bilateral, may be equal size or of different size. Then the uncinate process may be pneumatized also, and this is known as pneumatized uncinate process, like this example, and it may be medially deviated, encroaching on the middle meatus, or laterally deviated, encroaching on the osteomeatal complex. There is another abnormality in the uncinate process, which is known as atelectatic uncinate, and this atelectatic uncinate is adherent to the medial orbital wall. In this case, you will see that the maxillary sinus is hypoplastic, and the orbital floor is relatively low-lying compared to the opposite side. Then in the days before the era of CT scan and the advancement in the newer generations of the scan, we used to assess the paranasal sinuses by the plain films. But the role of the plain films has now relatively regressed in comparison to the advancement in the use of the CT scans, either the routine study or the full study. The role of the sinus view is limited to screening of cases of sinusitis and in some cases of trauma and possibly in, suspected foreign bodies. It may be used also for pre-operative planning or assessment of dental disease. But the actual judgment of the presence of paranasal sinus pathology or sinonasal pathology is the main task of the CT scan, which can be supported by MRI in specific cases. Here you can see mucosal thickening in the maxillary antrum on both sides, and in the plain X-ray, someone can say this is a clear sinus, others may say this is a veiling of the sinus, and someone may also say that this is an opaque sinus. But the main judgment is for the CT scan. Actually, we have some of the diseases that affect the paranasal sinuses, including the inflammatory and the neoplastic lesions, starting by the sinusitis, and you know that sinusitis may be in the acute form or in the chronic form, and we used to discriminate between acute and chronic sinusitis by the appearance of the fluid levels in cases of acute sinusitis and the concentric mucosal thickening in cases of chronic sinusitis. And this is a case of chronic sinusitis with concentric mucosal thickening of the right maxillary sinus, a case of bilateral air fluid levels in the maxillary antra that suggestive of acute sinusitis. There are some of the clinical notes that are written in the radiology books. This include that the imaging finding in sinusitis are usually non-specific and should be clinically correlated. And also there may be some mucosal thickening in the nasal cavity and ethmoidal air cells, which it may be considered as normal a part of the nasal cycle. And in cases of children, some of the mucosal thickening may not be due to sinusitis, and it should be clinically correlated as well. In this case, you can see what we call boloboidal mucosal thickening in the left antrum and concentric mucosal thickening in the right antrum. This arrow points to a localized mucosal thickening which is related to the osteomeatal complex. And in this case, you may say that there is some mucosal thickening in relation to the osteomeatal complex, and in the next section you can see that the osteomeatal complex is patent. And that's why you can see the antrum is clear, is not filled with fluid or mucosal thickening. Also, the diagnosis of chronic sinusitis may be done based on the presence of bone sclerosis of the walls of the sinuses, as you can see in this case with the operation done for sinusitis, and you can see that the wall of the maxillary sinus is markedly sclerotic. You can also see residual opacification of the sinus. Whenever we see what looks like a polyp in the sinuses, we usually diagnose this as a retention cyst. And the retention cyst is just the accumulation of fluid in the submucosa, resulting in a polyp-like in the sinuses. And actually, it is written in the radiology books also that polyps and the retention cysts cannot be differentiated for sure on the basis of imaging, either using the CT scan or MRI. But whenever we can see this appearance, which is total opacification of the maxillary of the paranasal sinuses, as well as masses in the nasal fossa merging with the nasal conchae, we can reach this diagnosis, which is known as the sinonasal bulbosus type. The imaging finding of sinonasal bulbosus type is expanded nasal fossa filled with masses, which are polyps, opaque sinuses which may be expanded, and in some cases you can see bone erosion, like in this case where you can see erosion of the frontal sinus. This is another case of sinonasal polyposis type, and you can see the opacification of the maxillary sinus as well as the masses in the nasal fossa. Sorry.
Sinonasal polyposis, erosion or expansion?
Yes, this one you may see some. Yes. Yeah. Yeah. No, and you can see this erosion is clear cut, not the aggressive type of neoplasm. I'll show some examples of one tumors. Yeah, and at the stage of this rarefaction, you may get breaching of the bony margin itself. But the neoplastic erosion is more aggressive, and you see more soft tissue component extra sinus. Then you can see this appearance, and we can say that this is a retention cyst, but the presence of this lesion and another lesion in the nose usually helps in identification of polyps, not retention cyst. And you can see another polyp in the maxillary sinus and a polyp in the nasal cavity, and this may be some of the helpful criteria to differentiate between retention cyst and nasal polyps. Our books also say that MRI can be used for discrimination based on the retention cyst is filled with water, then you get very bright signal in the T2 weighted image, while the polyp is formed of soft tissue and you will get less brightness in the T2 weighted images. Then the antroquanal polyp is the lesion that starts inside the maxillary antrum and extends outside the antrum into the nasal fossa and may reach also the nasopharynx. In this case, you will see that the antrum is relatively expanded, the osteomeatal complex is widened, the lesion is continuous between the antrum and the nasal fossa, and very important that the ethmoidal air cells are clear in this particular situation, so that you can easily discriminate this from a similar condition, which is the inverted papilloma. Then this is another case of antroquanal polyp. You can see the lesion in the sinus extending into the nasal fossa. And in cases of mucocele, you will see that the sinus is opaque and expanded. You can compare with the normal sinuses. These are the frontal sinuses which are clear. And here the left frontal sinus is normal. The right frontal sinus is expanded and is opaque. The imaging finding in mucocele include opaque expanded sinus, thin or eroded bony margin, and if you inject contrast material, in cases of mucocele, you will get marginal enhancement because this is an inflammatory condition. While in cases of malignancy, you will get heterogeneous or homogeneous enhancement. This is a frontoethmoidal mucocele with expansion of the frontal sinus and extension into the anterior ethmoidal air cells encroaching on the orbital cavity. And this is an example of maxillary sinus mucocele. The sinus is expanded, it is totally opaque, and the bony margin is relatively thinned out. Then you came to the fungal sinusitis, and the fungal affects the sinuses in three patterns. The non-invasive pattern, which is seen in immune-competent population, and it has two main appearances. Number one, you can see hyperdensity secretions or masses inside the sinuses, and this hyperdensity of the fungus is related to the presence of many pigments in the fungus itself, and this gives the fungus a hyperdense appearance either without or with contrast injection. Another appearance of the fungus is the presence of a fungal ball, and you can diagnose the presence of a fungal ball by the presence of calcium inside the fungus itself. You can see this mass of fungal infection, and this is the secretions of usual sinusitis, and inside the mass of the fungus you can see an arc-like calcification. Then in this case you can see infection of the ethmoidal air cells by fungus, and the sphenoid sinus you cannot see the hyperdensities characteristic of the fungus. Then if you perform an MRI, you can see one of the most characteristic appearances of the fungus, which is jet black. The fungus in MRI T2 weighted image will appear as jet black mass, while the usual sinusitis, due to its water content, will appear of bright signal. This is one of the ways to judge if this is important for the clinical management of the patient, whether this affection is pure usual sinusitis or with super added fungal infection. Then by invasive sinusitis, which usually occurs in the immune compromised patients, you can get intracranial and intraorbital extension with extensive bony erosive changes. And in this case with sinonasal bulbosis, you may feel that this case may be super added or complicated by fungal infection, and you cannot judge this unless you have the soft tissue window images. In the soft tissue window images, you can see the hyperdensities of the intrasinus lesions, which is characteristic of fungal infection. This is another case of fungal sinusitis with opacification of the maxillary sinuses and the ethmoidal air cells, and you can see in the soft tissue window the hyperdense appearance, which is typical for the fungal sinusitis. Also, you can see the affection of the sphenoid sinus with erosion of the cellular floor and the erosion of the floor of the sphenoid sinus as well by this fungal sinusitis. Then these are the criteria which can help in the diagnosis of fungal sinusitis by imaging. Number one, the presence of hyperdensities within the affected sinus on CT scan. Number two, the presence of intrasinus calcification in the fungal bore. Number three, marked signal loss in T2 weighted images. That we mean by very black signal in the T2, like this appearance. And you see this sinus is obliterated by sinusitis, and part of this sinusitis is due to fungus because of this very dark signal. Number four is the sinusitis which is refractory to medical treatment, and whenever maxillary sinusitis extends to the cheek, we may suspect the possibility of developing fungal sinusitis. Sinusitis may have intraorbital and intracranial complications. Intracranial complications include meningitis, like this, and you see thickening and enhancement of the meninges with some epidural emboyema here. Also, you can get subdural emboyema or cerebral abscess. This is a classic example of an intracranial abscess with marginal enhancement. And you may also get cavernous sinus thrombosis, especially in cases of sphenoid sinusitis. Orbital complications include orbital cellulitis in supraostial abscess and the cavernous sinus thrombosis, as I have said, which is commonly associated with cases of sphenoidal sinusitis. In this case, you can see ethmoidal sinusitis and maxillary as well, and the swelling of the ocular muscles, extraocular muscles, denoting myositis, which is secondary to ethmoidal sinusitis. And in this case, you can see opaque ethmoidal air cells, and the intraorbital you got inflammatory reaction of the muscles, as well as the preseptal area with evident proptosis. Then the neoplasms of the paranasal sinuses are divided into two main categories: the benign lesions and the malignant lesions. On top of the benign lesions came the osteoma, which is a bony mass formed of solid bone. It is commonly seen in the frontal sinuses, but may seen in the ethmoidal or in the maxillary antrum as well. It's dense bony mass with no enhancement, and multiple osteomas may be seen in a very well-known GIT syndrome known as Gardner syndrome, associated with colonic bulbosis. This is a classic case of osteoma inside the left frontal sinus. Also, fibrous dysplasia may affect the paranasal sinuses, and the fibrous dysplasia in the maxillofacial area characteristically affects the orbital roof. And in this case, you can see that the orbital roof is expanded, and classically it shows also the ground glass appearance. This is a classic case of fibrous dysplasia of the bony nasal septum, which has been expanded and showing the typical ground glass appearance. Two different cases of fibrous dysplasia of the orbital roof and the wall of the sphenoid sinus, showing expansion and ground glass appearance. And this is a classic case of fibrous dysplasia affecting the region of the maxillary antrum, where you can see the ground glass appearance and expansion, which is evident in this 3D reconstructed image. The inverted papilloma is a benign lesion arising in the nose, and it is usually histologically benign but is locally aggressive. And in this case, you can see a nasal mass that is merging with the nasal concha, and this mass may extend inside the adjacent antrum. And the classical way of diagnosis is the presence of affection of the ethmoidal air cells, so that you can differentiate between the antroguanal polyp and the inverted papilloma of the sinus. Then you can see here a case of inverted papilloma. The maxillary sinus is opaque and the lesion is continuous in the nose, and the ethmoidal air cells are affected. This is the difference between the inverted papilloma in this case and the antroguanal polyp. You can see the antrum is opaque, is expanded, and the lesion is getting inside the nasal cavity, and here the ethmoidal air cells are not affected. The ethmoidal air cells are not affected in the antroguanal polyp, but are affected in the inverted papilloma. One of the lesions that are intimately related to the region of the paranasal sinuses is the nasopharyngeal angiofibroma, and this is a very vascular lesion that is almost exclusively seen in boys, in spite of few reported cases in recent reported cases in females. And this lesion arises near the sphenopalatine foramen, which is located in this particular area, and it has the classic extension into the nasal fossa, as well as the nasopharynx, as well as through the pterygopalatine fossa into the infratemporal fossa. Also, this lesion may extend into the sphenoid sinus, and it has an intense enhancement because of its vascularity. And whenever you perform angiography, you can see marked vascularity of the tumor, which is usually embolized before operative excision. Then if you come to the malignant lesions, you will find an aggressive bone destruction of the sinus and the surrounding bony framework of the nose, as well as of the affected sinus. And this is quite different from the erosive changes secondary to sinusitis or fungal sinusitis. Then you can see a mass that is centered on the maxillary sinus with destruction of the anterior wall, extension into the cheek, destruction and extension into the nasal fossa, as well as in the infratemporal fossa. And in the lower down section, you can see erosion of the hard palate. Another case of maxillary sinus carcinoma with destruction of the sinus, extension into the cheek, extension into the infratemporal fossa, infiltration of the masseter, and the pterygoid plates. This is the case of maxillary sinus lymphoma in a patient with age, obtained from the literature, and you can see here that the lesion is destroying the anterior wall of the maxillary sinus and extending outside the sinus. Actually, we cannot discriminate lymphoma from carcinoma unless by biopsy. We can usually obtain these lesions through imaging guided biopsy, and is frequently performed for such lesions. This is a case of fibrosarcoma of the maxillary sinus, pathologically proved, and you cannot discriminate this from maxillary sinus carcinoma. And it's our policy in imaging to consider malignant lesion in the region of the paranasal sinuses as carcinoma until proved otherwise. Then this is an ethmoidal carcinoma that is obliterating the nasal fossa and the region of the ethmoidal air cells with retained secretions in both maxillary antrum. Also, we have a policy in whenever you identified a malignant lesion in the region of the paranasal sinuses or anywhere in the body, and you see that this lesion contains matrix calcification, then you may suggest the possibility of chondrosarcoma and osteosarcoma. And this is a chondrosarcoma of the hard palate on the left side, infiltrating the region of the hard palate as well as the region of the mandibular ramus and protruding into the oropharynx. Adenoid cystic carcinoma is also one of the lesions that is well known to spread along the nerve roots. And the spread of these lesions along the nerve roots usually affects the muscles that are supplied by these nerves. And if you see a mass inside the maxillary sinus, and this mass has extended outside the sinus to invade the pterygoid fossa, and you can see the difference between the mass and the secretions in the left antrum. And if you look to the muscles in this side. You can see the pterygoid muscles and the temporalis as well as the masseter, and here you cannot see the muscles because they are totally atrophic, denoting that the nerve root, the supplying nerve root, has been invaded by this particular tumor. This is not the whole landmark for the adenoid cystic carcinoma, but we use this sign, which is atrophy of the related muscles, to predict the possibility of adenoid cystic carcinoma. And this is a case of ethmoidal carcinoma affecting the ethmoids, extending into the nasal fossa and eroding the orbit, extending inside the orbit, and also inside the maxillary sinus. This MR image is used to discriminate the tumor from the secretions of the retained secretions due to obstruction of the maxillary sinus. And here the difference is too little, but in MRI you can see the difference between the tumor mass and the retained secretions. The paranasal sinuses may also be affected by tumors coming from the nearby organs, like cases of nasopharyngeal carcinoma can invade the maxillary sinus, and you can see the difference between a tumor invading the sinus from a tumor originating inside the sinus. We usually judge the origin of the tumor by the main bulk of the lesion. If the main bulk of the lesion is located in the nasopharynx, then you assume that this tumor has extended anteriorly to infiltrate the maxillary sinus. But in this case, you can see that the main bulk of the tumor is centered to the region of the maxillary artery. Also, some types of pituitary adenoma, which are non-invasive pituitary adenomas, can extend through the floor of the cella into the sphenoid sinus, and this is used for the diagnosis at judgment. We usually diagnose invasive pituitary adenoma if it has extended through the cellular floor into the sphenoid sinus. This is the end of my talk, and I used to show some of the quiz cases at the end of the talk. And this is a coronal image of the paranasal sinuses, and actually you know that this is the maxillary antrum. And what do you think about this area? Sorry? Yes, bulla squamous, and this is inferior turbinate, and this is uncinate process, and here this is the way of the osteomeatal complex. What do you think about this? Nasal septum and Kirsta galli and cribriform plate and middle turbinate. What is the diagnosis in this case? Maxillary sinusitis is not antecoronal polyp. Yes, okay. This is maxillary sinusitis with hypertrophy of the inferior concha and some thickening of the nasal mucosa. And you can also see a concha pillosa on the opposite side. What the... Okay. ما لو هي كانت في النيزوفارينكس كان لازم تبان هنا برضه ولا ايه رايك؟ بالظبط. فده مش وايدند قوي، وفي نفس الوقت لو في continuation in the nose it will be seen here, then you continue to the other section. في خناقة جامدة على الموضوع ده. بس it goes يعني if you compare this is the usual turbinate and you can see some air inside the turbinate itself. في بعض الناس لو في نقطة هواء واحنا ما كتبناهاش بيعمل مشاكل، يقول لك في كونكابولوزا and you missed the concabulosum. What do you think about this? Sorry? Yes, pneumatized bony nasal septum. What do you think about that? شفت حالات زي كده قبل كده؟ لا superior. طيب okay. Then this is one of the يعني I consider it one of the rare cases where you can see the superior turbinate originally and you see it pneumatized. This is more finding, and you can see this is pneumatized the superior turbinate on the right side. What do you think about this? Retention cyst, very good. And this infraorbital canal. And what do you think about this? Osteoma of the right maxillary sinus. And what is your diagnosis? This is an anthroconal polyp, is quite evident. Okay, what do you think about this? This patient had history of previous sinus surgery. You can see the defect. And the CT shows that the medial maxillary sinus wall, also part of the anterior sinus wall, are removed with residual bilateral mucosal thickening and uneven sinus wall sclerosis. What do you think? Which type? Chronic? Yes. هو ده السيرجيكال بروسيدر الحقيقة اللي اتعمل له. inverted babylon. Okay, لكن هو this case is obtained from the literature and it is diagnosed as chronic sinusitis with residual concentric mucosal thickening of both maxillary arteries. Then what do you think about this? Okay, bilateral concavullosa, and this is pharyngeal angiofibroma with characteristic hypervascularity. And what do you think? Sorry? المفروض كده صراحة. Inverted papilloma. This is an inverted papilloma. You see the lesion in the nose. You see the characteristic opacification of the ethmoidal air cells. This is an inverted papilloma. What do you think of this? Sinonasal polyposis. And there may be a superimposed fungal sinusitis, and you need the soft tissue window to be sure for that. What do you think about this? Yes, this is carcinoma because of the aggressive bone destruction, intraorbital extension. This is carcinoma of the ethmoidal air cells invading the orbit. What do you think about that? Retention cyst. What do you think about that? Frontal sinusitis. Very good. What do you think about that? Fungal bole. Very good. Mycetoma. What do you think about that? nasal septum is slightly deviated. ادي اول حاجه. concavullosa. تاني حاجه. very large halar cell and some mucosal thickening of both maxillary sinuses. Then forget about the MRI. What do you think about this case? Yes, very good. Inverted papilloma of the paranasal sinuses with characteristic obliteration of the ethmoidal air cells. Then what do you think about that? As there is opacification of the ethmoidal air cells as well as the maxillary sinus. And what about the orbital changes? Yes, the orbital cellulitis secondary to ethmoidal sinusitis. Then what do you think about that? Yes. Yeah, and you see the maxillary sinus is markedly expanded. This is a mucocele with super added fungal infection of the maxillary sinus. And I thank you very much.